Hello, welcome. I'm Katie Breen. I'm the Director of Program Management and Evaluation for the Colorado Perinatal Care Quality Collaborative, or CPCQC. Today is International Overdose Awareness Day, which is held in remembrance of the lives lost due to substance use disorder. The substance use and opioid use disorder crises have affected countless families and communities across the United States and, of course, across Colorado as well. Since 1999, there have been over 750,000 lives lost due to drug overdoses, and the latest numbers from the Centers for Disease Control and Prevention suggest an acceleration of overdose deaths due to the COVID-19 pandemic or during the COVID-19 pandemic. The Colorado Department of Public Health and Environment releases a maternal mortality prevention report, and the Maternal Mortality Prevention Program's latest report shows maternal deaths due to suicide and overdose are the two leading causes, respectively, of single-cause maternal death in Colorado. So I'm here today with Dr. Blake McLaughlin, who is an obstetrician and gynecologist and the Regional Medical Director of Women's Health Services for rural Colorado at Sterling Regional Medical Center in Sterling, Colorado. Dr. McLaughlin is part of CPCQC's AIM Substance Use Disorder Learning Collaborative, which focuses on establishing hospital guidelines and protocols for screening, brief intervention, and referral to treatment for substance use and perinatal mood and anxiety disorders at the time of admission for birth in hospitals. The Colorado AIM Substance Use Disorder Learning Collaborative is based upon the AIM, or Alliance for Innovation in Maternal Health, Obstetric Care for Women with Opioid Use Disorder Patient Safety Bundle. So thank you for joining me today, Dr. McLaughlin.
Awesome. Thanks, Katie.
Yeah. So let's start with what motivated you to be a part of the Colorado AIM Substance Use Disorder Learning Collaborative?
Yeah. Well, I think the thing that was motivating was some of the statistics that you just read. I mean, we kind of grow up as obstetricians, gynecologists, and OB providers thinking, postpartum hemorrhage, hypertension, preeclampsia, these are the things that are killing, moms. And certainly they are and have been historically. But for me to have the clear evidence in front of me and in front of us, and particularly in the state of Colorado, that the leading things that are killing or certainly causing, morbidity and harm to our patients and their families and community is mental health issues and substance use disorders. And so quite literally, that's sobering and an area that has really been neglected historically in what we engage in the peripartum care process for our patients. So that's what really drew us in of, hey, here's a real issue. The numbers, the stories are clear that this is something that needs to be addressed. And how do we do this and do this better and do this well to really impact our communities?
Yeah, well, awesome. Thank you for that answer. So I want to talk a little bit more about the goals of the Learning Collaborative. So I'm going to go through each goal, and you can discuss the progress your team has made on each goal or sort of what you've run into as you've been working towards them. So the first goal is that 100% of Colorado AIM Substance Use Disorder Learning Collaborative hospitals will implement a universal evidence-based and patient-centered SBIRT protocol for addressing substance use and mental health for all patients admitted for birth. And for people who are unfamiliar with the SBIRT acronym, it stands for Screening, Brief Intervention, and Referral to Treatment, and is really a best practice concept or paradigm for screening people and then making sure that they get the care that they need based on what the result of that screen is. So, Dr. McLaughlin, how has your team been working towards that goal of having 100% of patients screened using universal evidence-based and patient-centered SBIRT protocols?
Yeah, well, I want to answer that question and to maybe even backpedal just a little bit. I mean, what you described, right, is totally overwhelming for most of us on the front lines. I mean, a 100% goal, doing this thing that's universal, SBIRT training, screening, all of these things. And so I think for me personally, and for us regionally and at Sterling, it felt very overwhelming when we go through medical school and training. Our direction and our training is towards women's healthcare, and we sort of have a sense of what we think that means or looks like. We aren't typically going into that direction thinking primarily we're going to be addressing mental health issues or disordered substance use in the population that we're dealing with. Certainly we're aware that that's a part of it, but it isn't the main vein of what we're trained to do and educated to do. So it's super overwhelming. And
Yeah,
I mean, quite frankly, for me, it was intimidating to realize, okay, here's this huge need that we just alluded to and talked to a minute ago that really needs to be addressed. And yet, like, the powerlessness of feeling like, I don't know what the heck I'm doing in this area. And so I think I want to just say that out there, because I think many people watching this or engaging this are probably thinking the same thing. Like, I'm
totally.
pretty good at doing what I do clinically day to day and interacting with patients, but this whole thing is super overwhelming for many reasons. And I think too, for us, there is this, implicit bias that's present and the stigma that's present. And we have our own stories, right? Either within our own families of origin or our families or our community, where these things are tough issues to engage. So I think it's really important to set the context for this can feel overwhelming,
Totally.
and yet it's totally doable with the right support. And thank goodness CPCQC has said, hey, we are here as this infrastructure, this partner to walk you through this process. So I want to get that out there. To answer the question specifically, what we really did is, Banner is fantastic at being proactive and thinking about, okay, what are the needs that are out there and how do we build those into our workflows? And so some of this work had already been done, but what we did is we said, hey, let's take a pause. And again, this was hand in hand and working with CPCQC, Peer Assistance Services, other partner organizations, and saying, let's identify what our workflow is, current state, and kind of what happens in a tracer methodology, start to finish, what a patient's experiences is and what we're doing as a team and interacting with them. So we took a good look at that and realized, okay, we're doing okay, but we can do better, we can improve. And really, like, looping in and bringing in what are best practices specifically around, should every patient that is admitted get urine toxicology screening? Should every patient get which questionnaire, which screening tool? And so getting educated ourselves about what is current state best practice for these things was super helpful. So we were able to identify, all right, these screening mechanisms are evidence-based, they're proven to be appropriate for this patient population. And so we said, hey, we're going to take the first step and do that, and realize too in the process, to integrate that into our EMR right now would probably totally shut down the process and be a bottleneck. So we said, let's just bring this alongside in a paper form and train our nurses how to do that in a paper form. And there's a variety of reasons why that's actually beneficial. And then, so we took it in a sort of an analog fashion initially, and in the screening mechanism. Now, another huge thing is this: what is this SBIRT thing, and how do we do it? And we were able to again partner with Peer Assistance Services, free of charge. They came in and they provide educational sessions for nurses, residents, physicians, the whole entire team, start to finish, of taking us through a training program, so that we do feel confident and competent in providing the screening, the brief intervention, the referral for treatment. So we understand when we're having those conversations with patients that are difficult, that are hard conversations to have, how to do that and do that well. And so there's role play, there's practice in that training part of it. and it only takes a couple of hours, and you come out of that training feeling like, okay, I'm not so intimidated. I can have these conversations. I can engage this, and this is doable. So, I mean, that was incredibly valuable. And so building that into our training for our team. And then I would say one of the biggest obstacles that we faced is, how do we partner with these organizations in the community, regionally, statewide, that are already doing the good work and have figured out how to deliver this, treatment that's needed for patients, whether that's mental health relationships that are built, or medication-assisted therapy. These things that can be very intimidating, and we don't need to build from scratch. We don't need to reinvent the wheel. There are these organizations that are well-funded, well-resourced, fantastic people doing great work that we can partner with. And that was tough to do, but the relationships that came out of working with CPCQC and other organizations opened up those channels, and we have built some amazing partnerships with some local organizations within the community that we're able to then partner as we hand off patients that do need referral for treatment to the appropriate organization. So I would say that's kind of the process that we've been through to date. And I say to date because it's evolving. It's a living process, and we're constantly reevaluating and tweaking, what can we improve on and what needs to be addressed. So yeah, that's the answer to that first question about addressing the universal screening referral for treatment.
Awesome. Well, thank you so much. And yeah, I just have a couple comments based on what you said. Your note that this is a living process and you're constantly tweaking it. That's perfect. And I think, like you said, this work can be really intimidating. And, what you were saying with like the analog screening form, instead of, maybe not being able to get into the EMR right away, et cetera, et cetera. I think what we always try to emphasize, and it's very challenging because this work does seem so intimidating, is like, it's all about continuous improvement. It's a quality improvement collaborative, and quality improvement is all about, these little tests of change, having something be a living process, and constantly trying to improve and see, like, does this work or does it fall flat? And if it does work, what can we, do moving forward? Or if it didn't, what can we tweak? So I think, to your point, while this can be super intimidating, I hope people take comfort in the fact that it's okay that it's a living process, and really this is all about incremental change, because that's what quality improvement is all about. And that's the only way we're going to get to where we need to go is if we're willing to experiment and take baby steps and not try to boil the ocean in one day. Yeah, so I'm glad you mentioned that. And then I'm glad that you found the SBIRT training helpful, and I'll give a plug for the listeners out there who are interested in doing SBIRT training. We've been working with the awesome partners Dr. McLaughlin mentioned through Peer Assistance Services, which is an organization in Colorado that is funded to provide free SBIRT training to organizations. So if you're interested in that, feel free to reach out to us at info@cpcqc.org, and we would be happy to introduce anyone to Peer Assistance Services. They're an amazing organization in Colorado. And then lastly, you touched on some of the biggest obstacles being partnering with organizations in the community. And, I think that's an obstacle that everyone runs into. We've heard so often that, oh, well, we don't screen here, or like, I, as a provider, am afraid to screen because if the patient screens positive, I don't know what to do. I don't have anywhere to refer them to. And that's valid. It's also not a great excuse, to be honest. So part of what we want to do through this collaborative is encourage that community collaboration and provide support to connect our hospital teams to community organizations, so that, like you said, you don't have to reinvent the wheel. There are experts in your community who do know about medication-assisted therapies for substance use disorders, or who, do have the capability to do mental health counseling or help with social needs. And we don't have to take all of that on ourselves. We just need to, it's effort, but make the effort to establish those relationships. And I know that, you all at Sterling have done an amazing job of that. You had a rural perinatal behavioral health open house where you really brought in all of these great local community organizations and then also statewide organizations that could be accessed via telehealth to really show all of the perinatal providers in your region, this exists, and like, let's establish a relationship with these resources so they're not just like a name on a piece of paper. So I would just say, like, you all have done an amazing job of that. And it was such an innovative idea to think even to do the rural perinatal behavioral health open house. So great job on that.
Thank you. Yeah, yeah. And I would just say with that, if anybody listening wants to reach out to me anytime to find out how we did that or what to do, please do, and please reach me anytime. And Katie, perhaps you could provide my contact information.
We definitely will. Yeah,
because I'd be happy to help with that.
Awesome. Well, my next question, and you sort of touched on this already, which is great. So the second goal of the Learning Collaborative is that the teams will complete that brief substance use, maternal depression, and maternal anxiety screens using a validated tool for 100% of patients admitted for birth. And you sort of already touched on the 100% goal being a little bit intimidating. I wanted to ask them maybe a little bit more about the piece on validated tools, because we had heard from a lot of teams like, well, we're using something, but we don't know if it's validated, or we're not really using a tool, we're just asking a couple of questions. So I'm wondering what your team's process has been towards finding validated tools and using them.
Yeah, absolutely. That's helpful. Well, first of all, I would say something is better than nothing, right? And so, because it opens up the conversation, and so, kind of ignoring it or not asking the questions, not having the conversation is less helpful. Having said that, there are fantastic validated tools available for all of these things, for substance abuse, for maternal depression, anxiety, that are available and free as well. There are some tools that are available that do have a cost associated with them. We did not choose to use those. We chose to use some of the tools that are free, and so. And again, it's leveraging relationships so that I don't have to become the subject matter expert in the validated tool and the history and the process of that, but working with subject matter experts, which again, CPC, QC is the networker, right? I mean, that's what this organization does. It helps connect me with those in the field that can provide that resource. And we're able to say, hey, these are the tools that are available. This is how they work. Here's the pros and cons of each of them. And for us as a team then to say, hey, this works really well. We can do this. We can adapt this, and we can certainly deploy it. So I think again, it comes back to that relationship with CPCQC and these partner organizations that are all around us. I mean, I have been shocked at the number of organizations, the quality of the individuals in the organizations that are around that can provide this support. So it's just a matter of asking. And again, that can be provided through the connection here with CPCQC.
Yeah, well, I'm glad you find our network useful, because like you said, that is what we're here to do, is to foster those connections. And, if we don't know the answer to we probably know someone who knows the answer, or maybe we know the expert ourselves. So I'm glad that's been useful. And I know, so many teams have needed that support to figure out like, well, what are the validated tools? What are the pros and cons? Which ones should we use? And that is really our role, is to help make it easy for teams to see what tools are out there, decide which ones might work best for their teams and their process or EMR or whatever, and then just work collaboratively to keep you moving forward.
Absolutely. And to talk about the implementation, with the goal of 100% for the tools, one of the things I love about Sterling is we are a smaller community hospital, and everyone knows everyone, and we're able to be very nimble and agile in that way, and pilot these, unique opportunities and these process improvements. And so we can be very hands-on with the process. And at larger institutions where the volumes are higher, I love what you said earlier, you don't have to boil the ocean. It's like carve out a subset of the population there, perhaps the antepartum patients that are going to be admitted, and deploy this with a subset of the population and work on that. So kind of deconstruct the process and apply it to a smaller portion of the population at larger institutions, and then find out what works, and then you can expand and scale it up. So I think there's a ton of opportunity there. Everything doesn't have to be, we're not launching a rocket to the moon here. We're making, small movements forward for a really good cause, and to do it in that way is really helpful.
Yeah, I'm glad you brought that up about, you can just start with one population, because, in quality improvement science, they say all the time, like, start with one patient one time and then see how it goes, and then move on to 3 patients or whatever. And even with, our the data collection we do as part of this program, we know that it's not easy for all teams to be able to report data to us based on all of the admissions they have over the course of a month. And so, like you said, like, we'll work with different hospitals and say, well, why don't you just take a sample of the patients you had and give us the data for that sample of 10 or 20 charts or whatever, just so we have something to go off of. And it doesn't have to be, this giant intimidating undertaking. Like, if you have the opportunity to be part of a learning collaborative, or like a quality improvement collaborative, just know that a huge tenet of being part of it is having support for doing really small, customized tests of change that will work for your organization. And don't be, intimidated, because the whole point of the collaborative is to help you succeed and to help break it down into the small incremental steps that'll make sense for your team.
Absolutely. And I mean, along with that, finding champions is really critical. And one of the things that I'm so grateful for at Sterling is we have these family practice rural track residents, and who have jumped in and been involved in this and helped champion the process. But almost any hospital has, if it's a public health master's degree student, if it's a nurse that's working towards her nurse practitionership degree, there's different folks that are in their journey of training. And they need a process like this in part of their training and education for their degree, that they are great folks to be champions for this and take this kind of work on. And it is not completely overwhelming. It's doable. It's certainly doable.
Yeah. Totally agree. Yeah. I mean, we can help you figure out who those champions could be too. So I love that. My next question is, again, related to the collaborative. So we have monthly, what we call coaching calls, where the first bit of the content is a subject matter expert speaking on a particular topic. And then we also have quarterly learning sessions that are a little bit longer and also involve experts presenting on different topics on substance use disorder or mood and anxiety disorders in pregnancy and postpartum. So I'm wondering, is there any session or sessions that have stuck out to you that have been impactful for your team in terms of creating culture change or changing the way maybe you think about a particular element of this work?
Yeah, the two that really stand out to me would be one that I alluded to earlier, and that's the ESPER training, the screening, brief intervention, referral for treatment training. I mean, it was absolutely fantastic. And And in fact, we did live sessions and we recorded sessions so that, you know, new team members that are coming on can get the training as well. But it was really powerful because I think that can be one of the most intimidating, you know, components of this is you're face to face with a patient, and how do you have this conversation that's potentially awkward about, you know, disordered substance use, you know, or mental health issues. And so that was fantastic. And then I would also say that the other thing that's been really helpful out of the collaborative is the coaching on quality improvement, right? And so going through PDSA cycles and, you know, all of these things that can be like totally overwhelming if you don't have a degree or specialized training in it. But the way that those things have been broken down for us, and it really is hand holding through the process. And you know, again, this topic and these topics are can be very like subjective and qualitative, where most of what we engage in medicine, particularly in this area of medicine, is objective. What's the blood pressure? How far is the cervix dilated? You know, these things that are like that are very objective and not subjective. And so it can be intimidating to understand how do we engage all this stuff. But the framework that is laid out in these learning sessions is super helpful and really reduces our own anxiety. And I'm not joking about that. It reduces our own anxiety of okay, how we can engage this and how we can do this. And I can't tell you how many times I've sent you an email or somebody else on the team at CPC an email or Kevin Hughes at Peer Assistance Services and said, hey, help me with this. How do I do this? And I mean, the support.
And we love that.
Yeah, you guys do. You're right there. So it's good.
Yeah, well, I'm glad you mentioned all of that, especially because, you know, to your earlier point about, you know, when you're going into OB-GYN, you're not necessarily going in thinking like, oh, I'm going to be having all of these conversations about behavioral health. Like, that's not necessarily why you went into that field or specialty. So I think to your point about the expert training being valuable, you know, people aren't always comfortable having those conversations. It's not something you necessarily would have learned how to do or have done historically, you know, very frequently in your role. So I think, you know, some of the feedback we get so frequently on those expert trainings is like, it's so helpful to just have that practice of having those awkward conversations, understanding the principles of motivational interviewing. And I think like, it makes total sense that people aren't comfortable having those conversations. You know, I'm not a clinician and I find the motivational interviewing questions or like practice helpful because, you know, you could use it in any part of your life. If you have a friend and you're like, so you have a shopping addiction. I didn't know, you know, I wouldn't have known how to approach that conversation in a way that is non-judgmental and meets the person where they are and is yeah, like really leads the person towards what would be best for them in the moment given their readiness to change. And that is what the expert training teaches you how to do. And it's not a natural skill. I think it's something probably like therapists are really good at, but for those of us who aren't therapists, like we don't learn how to have those tough conversations. So that's, you know, what I really love about the expert training, and I'm glad everyone finds valuable. And then sort of the same on QI, like you said, like you don't necessarily learn QI principles. And I do think like QI can be very intimidating. When we say our goal is 100%, like without realizing that you are going to have your hand held to really help you get there, it's like, oh my God, how are we ever going to do that? And the whole point of QI is those baby steps and having that customized support and technical assistance where we can really help you get to your goals. And it sounds very, you know, when you're learning it, it sounds very academic and intimidating, and there are all these acronyms, but really our hope is that we can help break it down for people, make it feel digestible, and really just bring home the point that yes, there are these acronyms and yes, it sounds intimidating, but really when you boil it down, all it is about doing these tiny experiments and seeing what happened and seeing if it worked. It's like the science experiments you did in third grade. Like, oh, what happened? Oh, this happened. Okay, we'll do this next time. It's actually very simple. It's definitely not rocket science, but it can be intimidating because it is couched in this language that we're all really unfamiliar with.
Right.
So yeah, I'm glad that has been helpful, and I would encourage anyone who feels intimidated by quality improvement, don't be. Like, anyone can do it. You just might need to become familiar with the jargon around it, and then you'll be fine.
Yeah, yeah, absolutely. It's very logical, and having somebody that can walk you through it is so helpful.
Yeah, cool. Well, Dr. McLaughlin, thank you for joining us today and for sharing your perspective on the work. And as we wrap up the discussion, can you share a little bit with our audience about why this work is so important to you?
Yeah, good question. Well, first of all, I've loved being here with you today. Thank you for the opportunity, and I really do think this is incredibly valuable. And the more that I've waded into this, the more valuable I'm convinced that it is. And we because these areas, mental health and disordered substance use, they are really, cultural indicators of trauma that's just beneath the surface, really, for all of us, right? And so, certainly there can be genetic predispositions or environmental predispositions to these things, but for the most part, we know, with trauma-informed care and things like that, that the generational trauma, and thank goodness we're at a day and an age where we're starting to talk about this, the generational trauma, the racial trauma, the childhood trauma that really is, universally present and to varying degrees for different people and populations. These are the weed beds that grow out much of these mental health disorders, and then there, also the substance use disorders. I mean, people that are struggling with these things aren't defective people. And those of us that struggle with these things we're not defective, right? So I think, really it can't be an, us, them conversation or topic. It's a we conversation and topic of, to some degree, in some way, all of these things affect us. And the way that we handle our trauma and the way that we handle our stress, it affects all of us, right? So it's a we conversation, and critically important, because it isn't just in a silo addressing a mental health issue. I mean, where mental health begins, I mean, I say this to my patients every day, where mental health begins and physical health ends, there no one can say. I mean, it's all connected. You know that now, thank goodness. And then, really, it's not just addressing the mental health issue for this patient that I'm sitting across from today as like, great, did I get her Zoloft prescription? Or, hey, did we address her marijuana use during pregnancy? Check the box. It's like, no, as we engage these things as human being to human being and talk about these things, that really you scratch beneath the surface, the trauma that's there for every human being, you realize people need a lot of kind curiosity and care, and to be able to connect them with experts that can walk them through that journey of healing and addressing, the trauma that's beneath the surface, that's, creating or cultivating the mental health issues or the, disordered substance use. It's really valuable, right? So we're not just then affecting that patient that I'm interacting with and getting them a Zoloft prescription or helping them to get off of marijuana. We are shaping their lives and our interaction with them. And really, we've always done this in OB care, right? Is we do pap smears, we do public health things that need to be taken care of. And pregnancy happens to be a time and a window when patients are interacting with the healthcare system. So we leverage that. So that's why we're leveraging this. We're leveraging this window of opportunity that we're developing a relationship with a pregnant person to address these really core critical issues of mental health and substance use, so that we are helping to hopefully shape and redirect the course of their life. So their life is better, their child's life is better, their family is better, and really the community is better. And really, then we start getting into this thing that I'm excited about, and that's this legacy impact that just has ripples, across culture and generationally. And so That's what I'm excited about. And that's why this work matters. And that's why it's worth taking the time and getting past that understandable, fear, intimidation about engaging this work. It really matters. It really makes a difference.
Yeah. Well, thank you for stating that so beautifully. On behalf of CBCQC, I want to say thank you to Dr. McLaughlin. And on Overdose Awareness Day and every day at CPCQC, we are committed to improving outcomes for pregnant people, infants, and their families. So if you would like to join us in this important work, please email us at info@cpcqc.org. And thank you all for watching today.